Καλησπέρα σε όλους και όλες που για μια ακόμη φορά συναντιόνται μαζί μας Καλησπέρα σε όλες και όλους που για μια ακόμη φορά συναντιόμαστε στα διαδικτυακά μαθήματα που έχουν θέμα την υγεία και τη θρησκεία. Σήμερα έχουμε την εξαιρετική τιμή και μεγάλη χαρά να φιλοξενούμε ως κεντρικό ομιλητή έναν πολύ σημαντικό επιστήμονα από το διάσημο νοσοκομείο Johns Hopkins της Αμερικής, έναν διάσημο Έλληνα της διασποράς, τον καθηγητή Παναγή Γαλιατσάτο, που και οι Έλληνες είχαν την ευκαιρία να γνωρίσουν τα τελευταία 3 χρόνια της πανδημίας, καθώς μέσα στα ενδιαφέροντά του ήταν και πώς θα σωζόταν ο κόσμος από τα κακά αυτής της επιδημίας του κορονοϊού. Ο Παναγής ο Γαλιατσάτος, όπως και το όνομά του υποδηλώνει, έχει ρίζες ελληνικές, παρόλο ότι γεννήθηκε και μεγάλωσε και σπούδασε στην Αμερική, όμως μιλάει ελληνικά και είναι ένας πολύ ζεστός Έλληνας, παρόλο που σήμερα στην ομιλία του θα μας μιλήσει στα αγγλικά, μια και όλοι όσοι μας παρακολουθούν γνωρίζουν αγγλικά. Ο καθηγητής, ο κύριος Γαλιατσάτος, ξεκίνησε τις σπουδές του στο Πανεπιστήμιο Temple και μετά στο Maryland School of Medicine. Αργότερα ολοκλήρωσε την εκπαίδευσή του στο Johns Hopkins Bayview Medical Center σαν γιατρός, αυτό που λέμε στην Ελλάδα παθολόγος, και σαν βοηθός διευθυντής. Δεν περιορίστηκε μόνο στην συνήθη εκπαίδευση που έχουν οι Αμερικάνοι γιατροί, αλλά συνέχισε και έκανε εκπαίδευση στο National Institutes of Health in Bethesda, στο NIH, το περίφημο, και βεβαίως στο Johns Hopkins. Είχε ιδιαίτερο ενδιαφέρον για τα θέματα της δημόσιας υγείας και γι' αυτό πήρε ειδικά μαθήματα και βαθμούς και τίτλους και από το Πανεπιστήμιο Duke και από το Πανεπιστήμιο της Πενσιλβάνιας. Σήμερα είναι ένας από τους επικεφαλής διευθυντής σε projects τα οποία έχουν να κάνουν και με την ιατρική και με την προσφορά στον δημόσιο χώρο, στην κοινότητα, όπως παραδείγματος χάρη το Baltimore Breath Center και άλλες προσφορές στην κοινότητα, που μία από τις προσφορές του είναι και αυτό το βιβλίο, το οποίο πραγματικά έχει επανεκδοθεί πολλές φορές και είναι και ο τίτλος, θα λέγαμε, της σημερινής του ομιλίας, Building Healthy Communities through medical religious partnerships. Δηλαδή χτίζοντας υγιείς κοινότητες σε συνεργασίες με τις θρησκευτικές κοινότητες, με τις ενορίες. Παναγή, it's a great honor to have you with us today. Please go ahead and deliver what you have prepared for us. Thank you again.
Όχι, η χαρά μου και συγγνώμη λίγο που θα τα αλλάξω στα αγγλικά, αλλά η χαρά μου να είμαι εδώ να σας εξηγήσω πώς εγώ σαν ένας γιατρός που βλέπω ασθενείς στις μονάδες ιατρικής θεραπείας και βλέπω ασθενείς με προβλήματα στα πνευμόνια, πώς εγώ έχω καταλάβει να βγαίνουμε έξω στις γειτονιές και να βοηθάμε με τις εκκλησίες που υπάρχουν εκεί, μπορούμε να προοδεύσουμε την υγεία πιο πολύ που μπορούμε μέσα στα νοσοκομεία. So εδώ θα αλλάξω στα αγγλικά, in English, and I will share with you my story and the evidence behind it of going from critical care to community engagement. I will go ahead and share my screen, and I will dive into the presentation today. So thank you again. And hopefully, as Dr. Lino shared with you the title of the book that we have out, you'll understand where that book is driven from, but also as a critical care doctor, why it makes sense to do community engagement. So we'll bring that all together through the aspect of faith-based organizations. No disclosures. What we're going to discuss today are current health disparities around critical care pathologies, social factors that impact them, and how community engagement, specifically through faith-based groups, are able to allow us to promote health in a manner that can really achieve what healthcare and medicine in of itself cannot. So I start my journey of this early in 2014. As Dr. Linos mentioned, my critical care training happened at the National Institutes of Health in Bethesda. And at the NIH, we always invite speakers all over the world to come and give us a presentation. And Dr. Martin, the lead author of this paper that came out a decade prior, came and talked about the work that went into it. And this was a paper about sepsis, sepsi, right, dating back to Hippocrates' time. And up until now, even now, 2023, sepsis is really just thought of as this critical care syndrome, pathological syndrome, and the ownership of it academically is really emergency room physicians and critical care doctors. This paper, its intention was to be the first epidemiological paper to review the incidence of sepsis close to 20 years, starting in 1979, because that's where in the United States, we had this formal classification around coding for hospitals. And, the paper did just that. It achieved it. It showed the incidence of sepsis increasing over the decades. But what the paper actually also did, unintentionally, this was not an aim for it. It talked about differences in regards to sepsis around gender. Here you can see more men than women have it. And then in the last several sentences of this paper before going into the discussion, the authors comment on racial and ethnic differences. Now, this paper was not one to look into health equity or health disparities. It was meant to be an epidemiological paper of who's having higher rates of sepsis. But in these last closing lines, something stood out, because in the United States and around the world, race, the color of one's skin, is a social construct. And so suddenly you have a biological disease impacting socially disproportionate, very specific entity. And here in the US, Black African Americans as compared to whites, especially in Black men. And then a few years later, Barato out of the University of Pittsburgh, they put out another paper that reaffirmed kind of the conversations around Martin saying, yes, sepsis, the rise is occurring, and specifically in the older population. Sepsis really is associated with aging populations. And that's fair, and this paper does show this, but what Barato also showed was the sepsis disproportionate impact that we saw in Martin's paper actually begins really young, right? In the minority population in the United States, Black patients begin to experience disproportionate rates of sepsis early on. Now, look, I say this as a critical care doctor, as an intensive care unit physician. And I would see this and I'd say, what's going on, right? Because this isn't something that I can do and fix in my intensive care unit, right? I will treat everyone the same. But during my time at the NIH, I took my colleagues and I said, something's odd about these findings. Not that I trust them, but there's got to be something more to this. So what my colleagues and I did at the NIH is we performed a systematic review and ultimately culminating in a meta-analysis where we looked at all the sepsis papers dating back to the 1950s. We found about 120 of them that looked at population specific in the US. And out of those 123, 21 were pulled for the systematic review, and then about 6 for the meta-analysis. And what I wanted to look at was this non-biological term of sepsis, of race influencing sepsis. Is it the main driver? Is it just race, or is it more complicated than that? And in our study, we showed it is more complicated than that. Specifically, if you had these patients, regardless of race, live in rather poor areas, rather disproportionately disadvantaged socioeconomically areas, they have higher rates of sepsis. So the concept of race was lost the second you had neighborhood composition from a socioeconomic status evaluated. And so again, as an ICU doctor, this gets you thinking, because all of the catastrophes, this catastrophic pathological syndrome coming into the intensive care unit, your heart goes to, I wish I could prevent that from ever happening. So these contextual level factors, neighborhood composition, start coming to mind. When I left the NIH to join faculty at Johns Hopkins, one of the first studies we did was look at sepsis, specifically the death rates of sepsis in our city as it compared to income level of the neighborhoods. And again, what we found was if you lived in a low income neighborhood, you had higher rates of sepsis death. Now, what's fascinating about this study that we did, there's another component to it that we didn't publish, but I found fascinating. So sepsis, for those of you listening and wondering what this definition is, it's rooted in Greek, right? Sepsi. But what sepsis is, it implies that there's an infection and your immune system has an aberrant response to it, meaning it doesn't strike it in a way that is physiologically sound. It strikes it in a way that causes this catastrophic demise to the body. Your blood pressure starts falling, your breath and oxygen levels start falling, you're ultimately led to death, right? And it's really caused by the immune system's overreaction. Now, I say this because one thing you could say is, well, maybe there's higher rates of infection in poorer communities. A study, an evaluation of this data, what was fascinating to me was the flu, right? Because this predates COVID, this study. There were higher rates of flu in the richest neighborhoods of Baltimore City, but higher rates of sepsis from the flu in the poorest communities. That to me stood out. So it's not even infection rates that seem to be higher in the richest areas, but getting an infection in the poorest areas led to their demise, led to their death. Now, at Johns Hopkins, at healthcare systems in the United States, what tends to drive a lot of the decisions made is, can we treat the individual well in the hospital and then send them off back to their home where they can be at peace and recover? However, if that individual comes back to the hospital within 30 days specifically, readmitted for the same thing that they came in with, the hospital actually loses a significant amount of money. And so that's a huge concern for a hospital. In the United States, at any point in time, if you go to the hospital's population health committee and you say to them, what are the top 3 causes of your patients being readmitted? They'll tell you cardiac, pulmonary, and sepsis. Now, what's fascinating about this, it's cardiac, you send them to the cardiologist, work with their heart failure. Pulmonary, you send them to the lung doctors like myself, work with their emphysema, their COPD. For sepsis, what do? You don't have an answer. However, it costs hospitals every year in the United States millions and millions of dollars because of readmissions. This study that we did in 2020 was the first ever indication to show that what resulted in patients being readmitted, if you look down here where I'm about to circle, called the ADI, Area Deprivation Index. It's a score 1 to 100 that takes into account how well educated a neighborhood is, the income of the neighborhood, how many people are employed, how many people have transportation. Here in the US, the higher the number, the more disadvantaged it is. Meaning if you're at 100, you're at the most poorest neighborhood in America. What we found here in Baltimore City, patients that did not come back to the hospital, no readmissions, they tend to have come from middle-class areas predominantly. But those who were readmitted, they came from the poorest areas of the hospital, of the city. What we actually found here was that if you were young and poor, you will survive sepsis. You're just going to be on this horrible spiral of coming in and out of the hospital. You're never back to baseline. You're never back to the physiology that you once had. And this, what we began to find out, you can have the best hospitals provide the best care to manage their sepsis. But what ends up, you realize, is a lot of the factors that they are access to while in their neighborhoods where they live. Poor housing, poor transportation. In Baltimore City, it can take you 2 hours to go 2 kilometers because of the bus system. It's horrible. You have poor access to food, to nutrition. You're constantly eating rather processed foods, etc. Poor access to education. There's a lot in these communities that dictate poor health. And sure enough, if they get infected, what we found was they were more likely to develop sepsis. So the genesis of sepsis was dependent on where you lived. And this was true also for COVID. The first big study that revealed this 6 weeks into the pandemic, out of Louisiana, Price Haywood found that more Black African Americans had severe COVID, a type of COVID that resembles sepsis, happening to minority populations. At the same time, the rates of sepsis overall in this area, same for rich areas, same for poor areas, same for whites, same for Blacks, but Black minority populations suffered worse outcomes from it. Now, there's a lot of reasons to evaluate differences between two groups. As a physician, we do this all the time. Is there a biological reason? Are there behaviors? Is it access to good healthcare, or is it all the above? Now, I'm going to stop here, and I really want you guys to think, right? Because what I'm going to try to get at is here's a critical care doctor realizing I can do what I can in the intensive care unit. I can save these lives, but I'm sending them back to somewhere unhealthy. I'm sending them back to somewhere where they're just going to come back to me. And a lot of it has to do with their neighborhood. But what I need to figure out is if this difference that I'm seeing, that's also reflected in the research and in the data, is it a disparity? And this is a really important part to drive home. You can go and run research and go to your statistician and say, run me a model to make sure what I'm seeing between two groups is not happening by chance. Tell me that this is happening because of an intervention. You can run statistical models to assure you statistical significance. What do you tell your statistician if you say, hey, I want you to run me a model to prove it's not a disparity? So a disparity does imply there's a difference, but there's something more to that. Let me walk you through a little bit of exercise through it. In 2014, when I began my first year at the NIH, we had a physician from Milan, a trauma surgeon, come. And he gave this presentation about hemorrhagic shock, right? Bleeding out from trauma. And interestingly enough, he broke it down by faith as well. So in Italy, Catholics received a lot of blood transfusion. There was also a lot of Catholics that live in Italy. But there was one group that received no transfusions, zero, none. So statistically, that's a significant difference. The p-value, I assure you, is statistically significant. So I'm telling you here, the majority religion receives a lot more blood than this one minority religion. And you may say, that's unjust, right? That's a disparity. No, that minority population are individuals of the Jehovah's Witness faith. They don't accept blood transfusions. So yes, while it's a statistically significant finding, is it a disparity? Here's another one. Type 2 diabetes happens in older individuals way more than younger individuals. And you may say, is that a disparity? Right? Something that affects the older population, the elders, more than the youth. Is that ageism? The answer is no. We recognize type 2 diabetes is a disease of aging, of chronicity, of chronic exposure to certain things, and over time culminates in this disease. No one's fighting this. What about breast cancer? Men get breast cancer, but women get a lot more of it. Are we fighting to level the field, to say we need to get the rates of female-related breast cancer at the same rates as males? No, we don't fight this, because biologically we understand women have more mammillary glands than men, so they're going to have a lot more of a probability of developing breast cancer. What I'm alluding to here is you can run statistical models to show differences between two groups. You can do that. We have the statistics to do that. But to prove a disparity, it's not a real statistical model that I need. It's actually a reflection of society at that moment. Because a disparity implies that we will give it a perception of unjust. It implies that our view of these differences is avoidable, unjust, and unfair. That's a disparity. And the reason why I bring this up is when I reflected on the sepsis situation, I had to make a decision. Is it avoidable? Is it unjust? Is it unfair? And it seems to be happening between a privileged group and a marginalized group. The World Health Organization discusses social factors that impact health outcomes, and it takes it to this next step of recognizing that a lot of these social factors are created somewhat intentionally through politics, through economics, maybe sometimes through social norms and social policies. What I'm alluding to is there is going to be non-biological, non-medical things that will impact health outcomes way more than any physician could ever do this. And we know this. Look at, I always comment to my pulmonary team, my lung team. Look at those COPD trials. All of them had to stop smoking to take the inhaler. Then in the real world, that almost never happens, right? There's going to be behaviors that are going to offset the medical therapies we would like to do. In the hospital, it's a little different. We have control over this, but that's a moment in time. The patients are going to go back to all those non-biological risk factors that got them where they were at this moment. And when you study critical care diseases, you have to make a decision. Where are you going to put your most attention? And this is where whether there's a variety of reasons we choose in medicine as a science to pursue something that we want answered. And over my time as a critical care doctor, I couldn't turn a blind eye towards watching certain populations constantly come in my intensive care units and not say, we need to stop that. We need to take ownership over it. So from my standpoint, how I made the leap from critical care to community engagement began with recognizing that this disproportionate impact around sepsis and certain other critical care pathologies happen at the neighborhoods. So from my standpoint, when you study differences, you make a decision from a social standpoint. Are these unjust? Are these avoidable? And if they are, what are we going to do to fix that? And from my standpoint, the more we studied sepsis, this is one of my mentees, the more we realized its own influence comes from a lot of diseases like high blood pressure, diabetes, that are chronic diseases that also tend to cluster in the poorest of areas in the United States, in Baltimore City, for instance, specifically. So now we got to get further back to the genesis of this, right? Because sepsis, as I showed earlier with the slide, its disproportionate impact on minority populations, on disadvantaged populations, begins to happen early in life for them. This is preventable. So I am now a young faculty member at Johns Hopkins, and I take to the large offices and I say to them, you see sepsis. It's impacting from a mortality standpoint a lot of our patients, but it's also impacting the morbidity of those who survive it. They're coming in and out of the hospital, in and out of the hospital, in and out of the hospital. So the healthcare system views this as a population health goal. All right, we are going to help you stop the rehospitalization of patients who survive sepsis. And while that sounds great from a population health standpoint, you got to execute. You know, I view population health like grabbing a globe. Yeah, you have some insight, but if you really want to get to a location, you got to be on the streets, walking, maybe with a map to find your path. You can't sit at a 30,000-foot view trying to understand what's going on. And what I loved about our conversations with a lot of the population health offices was, hey, we will give you resources to do better with sepsis management in the hospital. And then we show them the data. We're doing great in the hospital. We have a low mortality rate of sepsis at Johns Hopkins. The readmissions has more to do with where the patients are going afterwards. So I convinced the hospital that we need to take this into the community's perspective and tying it into community health. And this is where we begin to pivot towards recognizing working with the community means understanding who that community is. And that overlap area that you see right in the center, that comes from community engagement. Now, one thing here in the United States, it is a diverse population. And there is a strong diaspora of Greeks, don't get me wrong, it's very enjoyed here, but there's a multitude of other populations and diverse communities and so forth. And what I realized early on is that if you want to do effective community engagement, to go out to really impact these non-biological factors that are resulting in patients pouring in disproportionately into the hospital, we need to learn how to be effective medical messengers. And when we identify the communities, how to best work with them, because every community is going to be a little different. And I say this because think of your own patients. Every patient's a little different. Well, let's first go to medical messaging. Medical messaging is important. We saw that during the pandemic. If you couldn't communicate the science in a manner that isn't just sharing information, if you could share the science that creates advocacy, that creates action, that's gold. That's it. We have to remember, medicine, being a field of science, isn't a culture, right? No one goes and prays at the altar of science. It's a string of objective facts. You, as a physician, as a doctor, you're the one who has to take this information and try to adapt it to someone's life and someone's identity. We do that constantly. We do that all the time, even if we don't really think of it. We're kind of like musicians, right? A musician knows every single note, and they could play every single note, but they don't. They know their audience. They take 3 notes, and they'll play them in some pattern that's enjoyable. And that's what we do as doctors. We know a lot about these diseases. We don't sit down with patients and give them an 8-hour presentation. We usually identify a few things that we believe will resonate with them. And we deliver that to hopefully make an impact, not just a sharing of ideas, but communicating a story that will motivate them. That's medical messaging. And if you do it well, you're sharing information, yes, you're resulting in some level of skill building, even if it's going to access a medication. And the most important part that I bring up is this, the social cohesion part. Can what you say to them align with who they are? Can you share something that in the science that will make them healthier, that reaffirms their faith? Yeah, you know what? As a Orthodox, I will do that. As a Jewish person, I will do that. As a Muslim, I will do that. And I see this because in America, we have that level of diversity. And so we have to recognize the medical messaging as we go out from our hospital to talk to the communities. We have to deliver it in a message that's important to them. And more importantly, can the message be passed on from one person to another? That's transitivity. It's kind of like gossip, right? It's like, sharing something and then he shares it with someone else and someone shares it with someone else. That level of the community, how tight is it, will tell you if your message gets around effectively. Homophily is another term that we look at when we review these communities. Homophily is a sense of, Greek, of course, but a sense of unity, shared beliefs. So if you have a community with shared beliefs, your message easier gets around. And finally, the communities you work with, is there a hierarchy? Having a priest, an imam, a rabbi goes a long way, because if you can talk to them and reach them and impact them, your message trickles down very nicely. So one of the things that we saw was that working with faith-based groups, yes, we work with schools, we work with housing buildings, we go into neighborhoods and nonprofits. Those are all important. But faith-based groups, your ecclesias, those were powerful. Those got the work done. And I see this because over the last 10 years, this is a picture of Baltimore City. Over the last 10 years, we have executed more than 10,000 projects in Baltimore City. In the last 10 years, we have saved the hospital well over $50 million in regards to preventing rehospitalizations, right? We did the calculations before I did these presentations, because we sit back and go saving $3 to $4 million here, saving that. And I know this is money, right? And I see this because it's more than economics, but those savings then go back into the healthcare system and go back into the communities. There's a gain here. But all these efforts and all this impact that we did wasn't because of a physician. It was because of the community that we empowered. One of our biggest projects that we did was working with spiritual leaders. In this picture is Reverend King and Imam Hassan. We worked with them, trained them in how to tackle those non-biological factors that you saw earlier that I discussed: transportation issues, housing issues, access to medical care, education. We taught them how to create a level of advocacy for the community to offset that. So when I say we were able to make an economic impact to the hospital, I said that in a way of really realizing if patients can drive their own health, it's much more cost effective and they don't necessitate hospitalizations. We saw a blip briefly in early in 2019, right into 2020, we saw a small drive of sepsis incidents coming down in some of the poorest neighborhoods. That's important to say because then we had the pandemic and everything else went away. Everything else got undone. But these gentlemen and many others were the reasons we implemented so many projects in our city around health. And we tied in these health interests with community health interests. Let me give you an example. Reverend King, for instance, we talked to him, this was 2017, we talked to him about the flu, high rates, right? We've discussed that, and a low rate of vaccination against the flu. And he looks at me and goes, Dr. Yedre, we're worried about jobs here. Our people can't find work. And if they find work, sometimes they're just too sick to work. And I made this case saying, there's evidence that shows if your community has flu vaccine, less days of missed work. If you miss a day of work, you don't get paid. At his church, at his ecclesia, we vaccinated over 300 people for the flu that year in 2017 because we heard what they said and we made a case the vaccines will help out with employment. Now, we published countless articles on how these lay health educators that we train coming from the ecclesias go back and start their own health ministries and work collaboratively with our own hospital and healthcare system. And it's been one of the most rewarding things to date of what we do and how we get out there and do this. So, the evidence continues to build. And then what I'm most proud of is in 2021, this is me. So you know me, I couldn't find a barber during a pandemic, so the hair got a little bit longer. This is one of my physician directors, Dr. Sharita Golden. And this is the Baltimore City mayor right here. And this is the health commissioner of the city. Baltimore Mayor Scott asked us at Johns Hopkins in the group that I oversee, when they realized we had really low rates of vaccine for COVID being taken up by the community, Mayor Scott said, we got to talk to the ecclesias. They have to help us. And the only people that really did it well and did it effective was our group. So the mayor invites us and says, you need to lead this medical religious conversation. And we did. And sure enough, we would go out to the communities, we talk to them. At one of them, Imam Hassan that I showed a picture of earlier, he quotes the Quran, and suddenly everyone nods their head. They're like, this is why we're going to get the vaccine. It was beautiful. Suddenly you had science aligning with their culture, with their identity, reaffirming their social cohesion. At the end of the day, that we have to recognize that's the beauty of modern medicine, is when it can reaffirm people's own identities. Right? People don't want to be patients. No one does. They want to be a mother, a father. They want to go to their ecclesia. They want to worship in the way they want to. If science and medicine can help them live those lives, that's what they want to achieve without disrupting who they are at their social core. So moving forward, one of the things I'll close with is, the building off that work. We have a large grant now for the next 5 years to do more of this, not just in Baltimore City, but in areas close to Washington, D.C., and in areas that are a lot more rural, right? So out in the farms of the state of Maryland, working with the ecclesias to train individuals to work with their communities there. There's other communities we could work with, of course, schools, jobs, etc. But to date, I think the power of working with an ecclesia, working with a church, working with a faith-based group, notes that they tend to work with the most disadvantaged individuals, those who really their health is at the worst. And they get to reach those in a trusting way that sometimes hospitals and healthcare systems struggle to create. I'll finish with this comment in order to take a few questions. Because doing this work, I will tell you, being a critical care doctor, I've had a lot of criticisms early on saying, how are you going to create a career for this? And I show them this evidence and say, look, you can save lives. You're just putting them back in, right? It's like, if someone's on fire and I threw water on them and then I threw them back into the fire, like that doesn't seem right. It doesn't seem just. But one of the things I always remind people at Johns Hopkins, we tend to talk about a physician called Dr. Osler. I'm not sure how familiar he is outside of the United States, a little bit in Canada because he studied medicine in Canada. But Dr. Osler is regarded as the father of modern medicine in the United States. And he started Johns Hopkins School of Medicine, right? He started the residency program and so forth. And we always talk about him. He goes to the bedside by the patient, the physical exam. He did a lot of great things for modern medicine. But there's a component that sometimes we don't emphasize enough. Early in his career, he went over to Germany where Dr. Virchow practiced, Dr. Virchow of the Virchow Triad and so forth. And Dr. Virchow is known as the father of social medicine because what he told to him was if you want to understand a disease, you go to where the people live. You go into their communities. You may not be able to understand what they're experiencing and, kind of walk in their shoes, but being bedside in the community will always tell you how these diseases come out. And then you, as a physician, should tackle that. Not just fixing the disease that they have, but can you help prevent it? Because that's what people want. No one wants to be a patient. And so this collaboration of medical religious partnerships, building healthier communities, as Dr. Linos mentioned in the book, to me, it's been the most rewarding work we've done to date. And the fact that we're able to prove it throughout the 10 years with a variety of projects that span not just critical care pathologies, but cardiac disease, pulmonary disease, endocrinological diseases with diabetes, continues to prove its worth. During the pandemic, we were able to vaccinate well over 90% of the population in faith-based groups because of our collaboration, not because of a yatre, of a doctor coming in there and talking. I did, and others did as well. But it was often the priest reaffirming that message, or the imam or the rabbi, their spiritual leaders. People really understand that their own identity comes first. How can modern medicine align with that? And when you can achieve that, you achieve greater outcomes. Now, as we talk, COVID severe incidences have come down. I'm not putting all the stock in the work we did. However, it was important in a multifactorial approach towards the COVID pandemic's part of severe COVID. Now, with this project, our HEAL initiative, health educators, advocates, and leaders, doing it throughout our state of Maryland, we're excited. And what I'm most excited about, in addition to just the work, is can we replicate this in other countries? Right now, we have projects as well looking at Brazil, Colombia, and Bermuda, and maybe one day also in Greece. So with that said, I'll stop here and leave plenty of time for Q&A with you all. Thank you so much. Okay? And the questions can come in Greek. Συγγνώμη που το είπα στα αγγλικά, but it's a presentation that I've loved giving and hopefully gives you an understanding that every physician should have a sense of responsibility that we can do more outside of the walls of the hospital. But I feel like saying this as a disciple, we go out to practice. So, Dr. Linos, I'm all yours for Q&A.
Thank you so much. We are so grateful for another inspirational talk and discussion, and μας βάζετε σε σκέψεις να αλλάξουμε και εμείς στην Ελλάδα και ως γιατροί να πλησιάσουμε με τον τρόπο το δικό σας τις θρησκευτικές κοινότητες. Μάλιστα, η πρώτη ερώτηση λέει: πώς σας αντιμετώπισαν οι ενορίες, οι θρησκευτικές κοινότητες στην αρχή? Πώς σας εμπιστεύτηκαν?
Θα το εξηγήσω έτσι, που πάμε όλοι μας να γίνουμε κάτι. Έγινα εγώ γιατρός. Αλλά πού έκανα το residency μου? Ήταν ένα νοσοκομείο δίπλα στις γειτονιές που εγώ μεγάλωσα, που ήταν η εκκλησία μου. Οι ασθενοί που έρχονταν μέσα, για τους άλλους γιατρούς ήταν ασθενοί. Για μένα ήταν ο θείος μου, ήταν ο γειτονιάς μου. Μερικές φορές ήταν ο παπάς. Λέω αυτό γιατί άλλαξα σε αυτές τις στιγμές. Δεν ήμουν γιατρός άλλος, ήμουν άνθρωπος και εντάξει, κατάλαβα τα γιατρικά. Λέω αυτό γιατί αυτό πώς άλλαξα στην αρχή. Πήγα πίσω στις ρίζες μου, ποιος ήμουνα και πώς μεγάλωσα. Γιατί εγώ που έγινα γιατρός, δεν έγινα γιατρός γιατί είχα γιατρό δίπλα μου και κατάλαβα πώς να είμαι γιατρός. Είχα την εκκλησία και κατάλαβα πώς να ήμουν άνθρωπος. Και σε αυτές τις στιγμές είναι σαν μια επίφανη που σε χτυπά και σε λέει να είσαι καλός γιατρός, πρέπει να θυμάσαι ποιος είσαι. Και λέω αυτό γιατί πώς μεγάλωσα και εγώ με τη θρησκεία μου στην Βαλτιμόρη και τις οικονομίες που τα κατάλαβα εγώ, οι δουλειές που κάνουμε μέσα στο νοσοκομείο είναι σπουδαίες, αλλά αν μπορείς και να βγεις έξω, να δώσεις το μήνυμα στις γειτονιές, στις άλλες εκκλησίες και να είναι διαφορετικά από τα δικά σου. Πηγαίνω στα Εβραίικα, στους Μουσουλμάνους, στις άλλες χριστιανές. Δεν ξεχνάω εγώ που είμαι Ορθόδοξος στην καρδιά μου, πάντα αυτό θα ξέρω. Αλλά εγώ πιστεύω όλοι μας είμαστε άνθρωποι, όλοι μας να δουλεύουμε μαζί για κάτι καλύτερο είναι σπουδαίο. Εγώ πιστεύω, αν πάντα σκεφτόμαστε ποιοι είμαστε, από πού ερχόμαστε, γιατί δεν είμαστε γιατροί, είμαστε άνθρωποι. Αλλά έτσι εγώ πιστεύω, έτσι εγώ έκανα αυτά που έχω κάνει και αλήθεια να σου πω, την Εκκλησία για μένα με έχει δώσει τη δύναμη και την εμπιστοσύνη να τα κάνω και να τα κάνω με την καρδιά που χρειάζεται. Έτσι σας απαντάω, ελπίζω ήταν την καλή απάντηση.
Με την καρδιά, η απάντηση της καρδιάς είναι πάντοτε πιο δυνατή. Μια άλλη ερώτηση λέει ότι είχαμε ακούσει τον Dr. Balboni για μια μελέτη που είχε κάνει για τους ασθενείς με τελική νόσο και ότι στη μελέτη του αυτή βρήκε διαφορές στην προσέγγιση μεταξύ των γιατρών και των ιερέων όσον αφορά την προσπάθεια των γιατρών να φύγουν νωρίς από το νοσοκομείο και τα φάρμακα όπου πια δεν είχαν δυνατότητα, και το ορισμένων ιερέων να τους επιμένουν ότι μπορεί να γίνει ένα θαύμα και να πείθουν τους ασθενείς και τους συγγενείς τους να παραμένουν. Ποια είναι η γνώμη σας?
Τα ακούμε πάντα αυτές τις ιστορίες, και είναι που εγώ που δουλεύω, που μιλάω με τους ασθενείς μερικές φορές και πολλές φορές και στις μονάδες ιατρικής θεραπείας, και τους λέω θέλω να κάνω τις θεραπείες να σε βοηθήσω. Λένε περιμένω ένα θαύμα από τον Θεό πριν να καταλάβω κάτι. Θα το απαντήσω με μια ιστορία. Έτσι θα το απαντήσω. Είμαστε τώρα στην πανδημία. Είναι το COVID σε αυτή τη στιγμή. Μας έρχεται ένας ασθενή. Αυτός γεννήθηκε στην Γουατεμάλα, ένα κράτος νότια από την Αμερική. Δεν μιλάει αγγλικά, ισπανικά μιλά, και τα δικά μου τα ισπανικά δεν είναι τόσο καλά. Τι έγινε όμως? Αυτός πήγε στην εκκλησία του που κάναμε COVID test. Είδε που είχε COVID, αλλά ο παπάς εκεί λέει δεν φαίνεσαι καλά. Πήγαινε στο νοσοκομείο, ήρθε. Και δεν πάει καλά. Δεν πάει καλά, εμείς το μιλάμε, πρέπει να το βάλουμε σωλήνα μέσα στο στόμα του, στα πνευμόνια του, να το βοηθήσουμε. Και σε αυτή τη στιγμή βγάζει τη μάσκα, λέει πάω σπίτι. Πέφτει το οξυγόνο του, θέλω να πάω σπίτι. Λέω, τι έγινε? Αυτός που είναι στο δωμάτιο που μας μεταφράζει, το θέμα είναι παίρνει τα αγγλικά μας και τα βάζει ισπανικά, αλλά δεν μιλάει σε έναν τρόπο που καταλαβαίνουμε ποιος είναι ο άνθρωπος. Λέω, τι έγινε, τι είναι θυμωμένος? Λέει, δεν ξέρω. Από πού ήρθε? Λέει, από την εκκλησία του. Πάρε τον παπά, το Father Bob λέγεται. Τον παίρνουμε τηλέφωνο. Σε αυτή τη στιγμή μίλησε ο Father Bob ισπανικά στον ασθενή, αλλά του μίλησε σε τρόπο που τον έδωσε πώς να καταλάβει τι συμβαίνει εκεί. Αυτά που κατάλαβα από τα ισπανικά είναι από το Θεό. Είναι αυτά τα βήματα που βλέπεις. Ο Θεός δουλεύει με τους άνθρωποι, με τους γιατρούς, με άνθρωποι. Θαύμα έτσι έρχεται. Σου λέω σε αυτή τη στιγμή, εντάξει, 10 λεπτά, μάσκα την είχε βάλει πίσω, τον βάλαμε τη σωλήνα, ζει ακόμα αυτός ο ασθενή. Αλλά τι θέλω να πω από αυτή την ιστορία να σας απαντήσω? Πρέπει να καταλάβουμε πώς να μιλάμε με τον κόσμο, και πολλοί ασθενείς άνθρωποι θα έρχονται με διαφορετικές ιδέες για την υγεία τους. Δεν είναι λάθη, δεν τα βλέπω έτσι. Μόνο πολλές φορές πρέπει να πάρουμε κάποιον να μας μεταφράσει αυτά που λέμε, να τους βοηθήσουμε. Και τη μετάφραση δεν είναι αγγλικά στα ισπανικά. Σε αυτή τη στιγμή χρειαζόμαστε τον παπά τους να μεταφράσει κάπως, να καταλάβει ο ασθενής πώς δουλεύει ο Θεός γι' αυτό. Εγώ και τη δουλειά που κάνουμε, φέρνουμε πολλοί που τους λένε chaplains, να μας βοηθάνε για αυτό το θέμα. Γιατί καταλαβαίνουμε εδώ στην Αμερική, βλέπουμε διαφορετικοί άνθρωποι και χρειάζομαστε όχι μόνο να μεταφράσουμε την γλώσσα μας, αλλά και τι πιστεύει ο άνθρωπος και να καταλαβαίνει αυτά που θέλουμε να κάνουμε. Θα βοηθήσει και τη θρησκεία τους. Δεν θα το χαλάσουμε, δεν θα τον αλλάξουμε. Σας απαντάω έτσι, γιατί είναι δυσκολία. Καταλαβαίνω και το βλέπω κάθε μέρα. Κάθε μέρα που είμαι με ασθενή και πολλές φορές στις μονάδες ιατρικής θεραπείας και που είχαμε με τα εμβόλια τα βλέπαμε. Δεν το θέλω, η θρησκεία μου λέει όχι. Και του λέω, πού, δείξε μου, έλα να μιλήσουμε. Πρέπει να καταλάβουμε, ο άνθρωπος είναι διαφορετικός, με διαφορετικές ιδέες, και δεν θέλω να το πω να είναι λάθος καθόλου. Πρέπει να τους μιλάμε, πρέπει να καταλαβαίνουμε πού έρχονται και να φτιάξουμε εμπιστοσύνη ένας με τον άλλον. Και πολλές φορές αυτό κάνει καιρό. Αλλά πρέπει να καταλάβουμε, αν θέλουμε να είμαστε γιατροί για όλους, αυτά είναι τα βήματα που πρέπει να κάνουμε.
Νομίζω με αυτά τα σοφά λόγια, Προφέσορ Γαλιατσάτος, θα τελειώσει η σημερινή μας συνάντηση. Σας ευχαριστούμε για άλλη μια φορά και ευχόμεθα να σας έχουμε και από κοντά στην Ελλάδα κάποια στιγμή. Καλό απόγευμα για την Ελλάδα. Καλή υπόλοιπη ημέρα για σας.
Ευχαριστώ και η χαρά μου πάντα να είμαι εδώ μαζί σας. Ευχαριστώ πάρα πολύ.
Ευχαριστούμε πάρα πολύ.